Morning, everyone. Thanks for tuning in. My name is Dr. Kevin Stinson. I'm a microbiologist and infection control practitioner by background and the program manager for infection prevention and control at St. Mary's General Hospital and Grand River Hospital in Kitchener, Ontario. This is a post-hoc recording of a live session that was done on 16 May 2024 as part of the IPAC CSO Education Day, talk called Group A Streptococcus, a disease with many faces. The intention at the time was always to have this as a recorded session after the fact, and to utilize this as a lead-in for a future session this coming summer 2024 as part of the IPAC CSO Clinical Rounds program. And so we're doing this recording today as that preamble talk. Of course, because this is a post hoc and not live recording, all of the interaction and all of the polls, the interactability of the original talk has been removed. But we hope that what we've done is taken a lot of those concepts, a lot of that narrative, and brought it into the talk. And of course, because we're not constrained necessarily by that 1 hour or 45-minute time slot, we can go a little bit more into depth with some of the details and around concepts of group A strep. Our hope today is that we'll dive into a little bit of microbiology, a little bit of immunology, a little bit of history about group A strep, and of course our IPAC management practices. So when we think why group A strep and why this topic, it's important to recognize what was happening in Ontario around the time that we were picking topics for our education day, so January 2024. So the January 2024 experience with invasive group A strep was quite severe. So on the screen here, we have the PHO invasive group A strep surveillance data. This one was dated early April, so it's data up until the end of March 2024. We can see across the bottom here in this green line, this is our 5-year rolling average of the 5 pre-pandemic years. Of course, most infectious disease, including group A strep, we saw a lot of suppressed transmission during COVID-19 as a direct impact of a lot of the COVID-19 pandemic measures that were put into effect throughout the community. Into 2022, 2023, our first true post-pandemic year, we see this very significant resurgence with very, very high levels, not typical for what we see in Ontario. And then this blue line represents the 23-24 year, peaking up here in January of 2024. And this is obviously a significant burden of illness, significant burden of caseload and disease, unlike anything that had been seen in the province before, just from sheer volumes. This was somewhat exemplified in our organization when one morning I walked into our ICU and was speaking with one of our intensivists who was quite upset at the events overnight. The day before, we had admitted a fairly young 32-year-old male into the organization, no significant comorbidities, no significant past medical history. And he was admitted in with a sore throat, severe fevers that's now led into altered level of consciousness, hypoxemic respiratory failure requiring intubation, and was brought to the ICU. And unfortunately, despite starting antibiotics, despite starting resuscitative care, he did expire overnight. So this young, healthy 32-year-old with no real comorbidities came into the organization and passed within 24 hours of what we later found out, or found out later that morning, was indeed group A strep in the blood. Now, this was coming off of a period of time where we'd had about, for over a 2-week period, at least 6 very severe cases of invasive group A strep, many of those coming to ICU and unfortunately expiring. We still had 1 patient down in ICU that the resident was just about to leave ICU to go and assess for probable admission. Again, sore throat, severe probable sepsis, likely a group A strep. We had a patient in another bed with a severe streptococcal meningitis. We'd had multiple cases of necrotizing fasciitis, multiple cases of death. We had a patient with severe streptococcal toxic shock currently being followed by our CCRT team up on one of the medical floors and would likely be coming down to ICU later that day. So quite a high burden of disease, quite a high burden of morbidity and mortality. So the question that our intensivists and our resident asked was why? What's driving this significant case volume? What's driving the significant caseload and severity? And why are we all seeing it now? And so that's the question we're going to try to look at today, is that concept of why. And to really dive into that, I think it's useful to look a little bit at the history of group A strep. Because group A strep is a disease that has really come up frequently in the history of medicine, come up frequently in the history of humanity. It's come up frequently in the history of infection control. It certainly goes quite a ways back in time. There's reportings of group A strep through medical literature, all back to into ancient antiquity, or what we assume is group A strep-like illness. Saint Anthony's fire, a very common saying through a lot of history, is thought to be primarily attributed to erysipelas. There was a few other potential cases or potential causes. Herpes zoster or ergotism are also thought to be attributed to St. Anthony's fire, but certainly group A streptococcal disease was among them. And group A streptococcal disease, even into fairly recent time, was an absolutely terrifying illness because there was very little management that could be done once group A strep hit the blood other than supportive care, and it had a very high mortality rate. But perhaps when we look at history, one of the most significant events in history that illustrates group A streptococcal disease is when we look into the 1600s in Paris, France, and we have the Hotel Dieu in Paris. Now, this is, of course, a very famous hospital, thought to be, I believe, one of, if not the longest continuously running hospital in history, having opened originally in the 9th century. Now, I'm presuming a different building now, otherwise it would be an infection control nightmare. But has just had that constant presence in the city of Paris since the 9th century. Now, into the early 1600s, 17th century, you saw a lot of modernization of medicine, and this idea of university-educated physicians really taking over a lot of care and bringing a lot of care into institutions. And the Hotel Dieu was no different. Now, the Hotel Dieu had always specialized in free healthcare to the poor, the homeless, the underserved, underprivileged in Paris. And because of that, it provided both shelter, it provided healthcare, it provided food banks or equivalent type services. And so you had a very large number of people seeking access to this. And you had then, because of that, overcrowding all through the organization. It was, of course, the 17th century, so very, very poor state of hygiene, very poor state of general health. And that's, of course, common with anywhere through the medieval ages. So when we look now at the early 1600s, Hotel Dieu was actually credited with one of, if not the first, lie-in maternity ward in humanity. And this was that attempt by now university-educated physicians to take control over obstetrics and gynecology as a profession and pull childbirth and pregnancy care away from midwifery into the hands of physicians. And because they were pulling it into their hands, they wanted their patients co-located in one location, and they created these wards they called, well, maternity wards or lying in hospitals. And so with these lying in hospitals, women would deliver their children, often in very poor sanitary conditions, and would spend a few weeks recovering the organization. About 20 years after the original opening of this, Hotelier started reporting something novel, and that was the world's first recorded outbreak of a condition called childbed fever. Now, when we had this conversation with the group in the live session, the question was asked is, who's heard of childbed fever? And there was next to no hands to the room because it's not really a condition we hear of today. We do have a modern equivalent title for this illness. It's puerperal sepsis. And the intent here is that as you have placental detachment, you end up with, in effect, what is an open wound within the uterus, where that placenta was attached to the uterine wall. As it detaches, it leaves a fairly easy conduit for bacteria into the bloodstream. And so any bacteria that was translocated into the uterus during the laboring process has now a lovely portal of entry into the bloodstream. And so we do still see now this idea of post-maternal or neonatal or post-birth or neonatal sepsis, puerperal sepsis. But the definition that was really used a lot in the medieval age was this idea of childbed fever. You'd have a mother lying in the bed that she delivered her child in, develops a fever, and almost invariably dies. And so through Hotelier, we had this large-scale outbreak that eventually subsided and just continued over the next couple of centuries, continued to see sporadic epidemics of childbed fever. And as more and more maternity hospitals across Europe opened up and this model spread, you had these pockets and epidemics of childbed fever striking all of these maternity hospitals. Still, women flocked to these organizations for that opportunity of weeks of bed rest monitored by physicians and nursing care after delivering their child. But should they have gotten childbed fever, gotten caught in one of these epidemics, their mortality rate was very high. And as you look at some of the historical documents on this, you have ranging anywhere from 20% to an 80% attack rate. And so some organizations through Europe reporting that during an epidemic, 80% of laboring mothers would pass from childbed fever in about 3 days after delivery. And so this continued into about the early 1800s until a Vienna obstetrician named Dr. Ignaz Semmelweis, which some of you may know the name as the father of hand hygiene, started to do some observations on his units. Now, in his Vienna hospital, their obstetrics program had two distinct units. You had the Unit A, which was led by physicians, and Unit B that was led by midwives. And despite very similar patient populations, despite similar environment, despite all of these similarities between the two blocks, the physician-led block had a 18% fatality rate from childbed fever. The midwife block only had a 2% fatality rate. So Dr. Ignaz Semmelweis asked, why? What's really the difference between these two groups? And through a lot of analysis, what he eventually discovered was the biggest difference was driven by the fact that on the A block, on the physician block, because this was tied to medical learning, you had all these residents also coming in and doing the learning. And you would have residents and physicians would go and perform autopsies on mothers who had just passed from childbed fever, come back and immediately go and start delivering more children. And there's stories come out of this of obviously quite poor sanitation, physicians with blood spattered frocks from their autopsy, physicians carrying organs and body parts and visceral membranes in their lab coats as they then went to deliver more babies. And inevitably, you would go into an autopsy perform an autopsy, go and deliver a child, and that mother 3 days later would be dead from childbed fever. On our midwife ward, there was no autopsies because there was no teaching side of the house. And so Dr. Ignaz Semmelweis concluded, or at least hypothesized, that what he called cadaverous particles were being carried from the autopsy to laboring mothers and causing a transmission of childbed fever. Now, at the time, this is after now the work of Anthony van Leeuwenhoek to discover the concept of bacteria. Hadn't been discovered, of course, back in the 1600s in the Hotel Dieu epidemics. So we knew what bacteria was at the time, but this was still before the advent and the work of Louis Pasteur and Robert Koch and Joseph Lister that really helped to put the idea of germ theory into practice. That would come over starting into the next 20 years after Dr. Semmelweis's death. And so Dr. Semmelweis tried a process where everyone on his care team was required to wash their hands. Now, unlike the modern, nice, emollient-rich, alcohol-based hand sanitizers, this approach was to wash hands with chloride of lime solution. Quite caustic, quite rough on the skin, I'm sure. But with that practice in mind, mortality rates dropped, and he was very quickly able to bring his case mortality rates down to match that of the midwife side. Now, you'd think that this would be widely adopted, widely taken up by all of his colleagues, but unfortunately, that is not the case. This perspective was viewed as very rash, very contrary to the current opinion of physicians at the time, which was physicians were gentlemen, they were university educated, they could do no harm. And in fact, you often heard through the medieval ages and into the 19th century, this concept of godliness over cleanliness of a lot of physicians at the time. And so because of that, Dr. Semmelweis's work was largely ridiculed. He was probably not the most or the best at trying to educate topics. He would very often yell at his colleagues that they were murderers if they refused to wash their hands. And unfortunately, he did suffer in his early 40s. A mental breakdown, was put into a mental institution, and within a few weeks passed away, which ironically is thought right now to have been due to a cut on the finger that became infected with group A strep. So like I said, it wasn't until the work of Louis Pasteur about 20 years after his death and subsequent work in the late 1800s, early 1900s by Joseph Lister and by Robert Koch that really put into concept this idea of germ theory, this idea that bacteria can cause disease, and truly brought Dr. Semmelweis's work back into the forefront and exonerated him. We go a little bit further forward in time, we have World War I. So World War I, of course, one of the bloodiest, most significant conflicts in modern days, huge fatality rates of soldiers, civilians, everyone else across Europe. Something around 17 million people died during the conflict. And a significant number of those were deaths attributed to battlefield wound injuries, or battlefield wound infections, rather. And so if you're looking at the photos on there, you can see that this was certainly not exactly a highly cleanly environment that soldiers were working in, often in the mud, often in water, often in the dirt, in what's described as well-tilled, richly manured fields. And so you have all of those organisms in that manured soil, that manured farmland, in and around where the soldiers are living, working, fighting, and dying. And there's many stories through World War I of soldiers who, after a battle, would lie in a crater or a foxhole with quite ragged shrapnel injuries, gunshot injuries, explosion injuries, and would be lying in the mud and lying in festering water for multiple days prior to finally being captured or taken, recovered, sorry, not captured, recovered and brought back to an aid station. The aid stations at this time weren't very good. They weren't exactly mobile hospitals like we see with modern military forces today. A lot of times this was aid stations set up in barns, in farmhouses, in tents with very, very little sanitary conditions to work with. The other thing to consider is at this time, we knew bacteria caused illness, we knew bacteria caused disease, but we didn't have a good way of managing that. And so the dogma on how to treat infected battlefield injuries to try to prevent gangrene, to try to prevent sepsis, to try to prevent that infection of those wounds was an idea of external antiseptic therapy. And so it was a common sight in field hospitals to see soldiers with tubing sprouting out from a tightly bandaged dressing, and that tubing would be instilling harsh antiseptics into the wound. Boric acid, phenol, carbolic acids, quite strong antiseptics. So, and then a number of scientists did a lot of work on the British side to really look into how was pathogens in these wounds causing illness. Sir Almroth Wright, one of the most famous physicians at the time in Europe, or in Britain rather, really did a lot of the work to identify that of all of the pathogens through these wounds, Group A strep was the most significant pathogen in about 70% of battlefield deaths. Not to say it was the only pathogen there. Certainly there was Clostridium perfringens, Clostridium tetani, Staphylococcus, E. coli, and other gram-negatives from the from fecal contamination, and the list goes on and on and on. But Group A streptococcal disease was deemed to be a significant pathogen in 70% of deaths. And so this really led to a lot of work in trying to prevent streptococcal infection. Sir Almroth Wright had done a lot of work with vaccination and serum therapy, and we'll talk a little bit about why this failed with Group A strep in a few slides. We also had Alexander Fleming, a name that folks probably remember from the individual who discovered penicillin after the war in 1928. Alexander Fleming did a lot of work taking test tubes and drawing out glass of molten test tubes into these fine little points to simulate a battlefield injury, flooding it with bacteria and then flooding it with antiseptics to show that those deep pockets of the wound did not cure or were not able to be penetrated by antiseptics, and bacteria could survive and thrive. And so this idea of antiseptic therapy really was not working. On the other side of the war, on the German front, there was a physician by the name of, actually was not a physician yet, a medical student who had become a grenadier and subsequently a medic by the name of Gerhard Domach, was working in German field hospitals, and much the same experience, was overwhelmed with this perspective of the number of infections and battlefield injuries that were causing death. After the war, these two individuals on opposite sides of the war, Alexander Fleming on the British and Gerhard Domach on the German front, both went off and really devoted a significant portion of their life to trying to come up with ways of treating streptococcal or other wound infections. Both of them are then credited with finding the first two antimicrobials that were really put into broad, widespread use. And of course, when we ask this question, everyone is very quick to throw penicillin as that first antimicrobial into wide, broad spread use. And of course, penicillin was perhaps the first to be discovered in 1928. That work was actually largely forgotten because of challenges with reproduction of that work until into the early 40s. And so it was actually Gerhard Domach who discovered Prontosil or sulfanilamide as an antimicrobial in the early 30s. That was the first true antimicrobial in broad use across Europe and across North America. And his main focus on that research work was group A strep. So this gives a little bit of the context around the significance of group A strep and other streptococcal diseases into forming a lot of our modern IPAC practices around hand hygiene, really influencing the severity of illness and really forcing this function of antibiotic discovery, with multiple scientists going out and discovering antibiotics secondary to this significant burden of illness and wound infections through World War I. So I then ask, despite the fact that we now have antibiotics that will target group A strep, why do we still see it as such an effective pathogen today? Because we do still see it quite frequently. We see very simple cases of group A strep. We see severe cases of invasive group A strep. And even on modern Ontario hospitals with modern science, antimicrobial therapies, the ability to sustain people in ICUs, we still have case fatality rates as high as 10% from invasive group A strep diseases. So what makes group A strep such an effective pathogen today? And first, perhaps we'll say, what is group A strep? So when we say group A strep, we are referring to Streptococcus pyogenes. Strep pyogenes is a gram-positive beta hemolytic cocci. You can see on this image at the top of the screen, this is a blood smear gram stain, and this would be a very typical gram-positive cocci in pairs and in chains throughout here. Quite a high burden of strep in the blood there. And so this is where the term Streptococcus comes from, strepto being chain and coccus being balls, so a chain of balls. Hemolytic or beta hemolysis is this idea of the ability to lyse red blood cells. So you see this plate at the bottom of the screen. You can see the colonies are the opaque dark white centers, and this zone of yellow around it is actually lysis of the blood in that Columbia blood agar. So it's that ability to completely lyse red blood cells that we call beta hemolysis. This remains now a top 10 cause of infectious disease death on a global front. And as I said, most of this, we still see this all the time in Ontario. We still see deaths from this in up to 10% of cases. But of course, if you transplant that experience to third world countries, to underserved and countries, to under-resourced countries, you see that mortality rate starts to increase significantly. And there are still millions and millions of deaths every year due to group A strep. When we then think of what really helps to drive group A strep transmission, it's important to also see that group A strep is a host-adapted pathogen. Humans are the only significant reservoir of group A strep. We don't find significant environmental reservoirs. We don't find significant animal reservoirs. It has to live and reside within us as humans. And so because of that, we need to have colonization of healthy adults. And so we do see about 5% of healthy adults at any given point in time are colonized with group A strep. Now, when we look at children, school-age children have a colonization rate significantly higher. 20 to 60% is the best average. 20% was a more of a traditional estimate, but a lot of studies have been done into the years leading up to the COVID pandemic, through COVID, and into the post-pandemic era, and seen this as high as 60% in some cohorts. And you can extrapolate that as well and say that groups of adults living in very tight quarters, so university dormitories, military barracks, that colonization rate does start to creep up. We also see that adults with household exposures, so household exposures, for example, to children who are colonized with group A strep. My 2-year-old at home has brought group A strep home several times from daycare, have an exposure rate significantly higher than the average population at upwards of 25+%. And we start to see a lot of secondary attack rates in those where kids will bring group A strep home as strep throat from daycare. And normally it's not easy to transmit this. You need to be sharing cups, sharing cutlery, sharing drinkware, or having a toddler with his slobbery hands grab goldfish crackers and shove them into your mouth, which certainly doesn't help with a infection control strategy to preventing transmission. So group A strep then causes a very wide range of illness. And we can see this idea we can colonize multiple sites in the body. So throat is probably the area that we think most commonly when we think of group A strep colonization. But you can have colonization on the skin. You can have colonization in the genitourinary and gastrointestinal tracts. And these can all cause some degree of localized or somewhat invasive illness. So we think we have a local colonization of the throat that can become a nice pharyngitis. We have local colonization of skin, can become impetigo and pyoderma. These can then progress into a more invasive disease, or maybe better definition is more of a body system infection or an organ infection. GIGU can become endometriosis, peritonitis, neonatal sepsis, or that puerperal sepsis. Our pharyngitis can become our peritonsillar abscesses, otitis media, sinusitis. Impetigo and pyodermis can become cellulitis, erysipelas, or St. Anthony's fire, necrotizing fasciitis. And then these can invade further, and we can see this idea of more invasive disease through the body. So bacteremias then seeding pneumonias, seeding meningitis, seeding osteomyelitis. We also see these other two types of diseases associated with group A strep illness. Or rather two types of illness associated with group A strep disease. So toxin-mediated diseases, where the release of streptococcal toxins cause scarlet fever in children, or streptococcal toxic shock syndrome in adults, both more or less the same pathophysiology driving that. It's that idea of cytokine storms brought on by superantigen productions. We also see this very, very strange immune sequelae in a subset of cases. So two acronyms that everyone may be familiar with: acute rheumatic fever and rheumatic heart disease, which the mechanism is not entirely clear. There's some hypothesizing we can bring up in a slide or two. But there's also this idea of a acute post-streptococcal glomerulonephritis, or APSGN up here. And this is an immune complex mediated disease where antigen and antibody in the bloodstream form immune complexes. These flow through the bloodstream until they hit small vasculature networks. One of the most common ones that will filter a lot is, of course, the kidneys. They'll deposit into the capillary beds and cause that glomerulonephritis just from inflammation as they hit capillary beds and lodge in those spaces. So this is a very, very broad range of illness caused by one little bug, and it largely depends on where does the bug hit, where does it invade. But we still have to sit there and say, well, what really causes a simple skin infection to become necrotizing fasciitis? That's a very wide or big jump of illness. And so this broad range of disease, we could just see a few examples of it here. We have a case, a poorly cut off case of a osteomyelitis up here. We can see that the patient did have a couple of taps into the knee. Our nice simple pharyngitis with that typical classical look of group A strep pharyngitis, tonsillar exudate, with severely inflamed tonsils, an impetigo case in a child where you have that yellow crusting lesions, and then a very severe case of necrotizing fasciitis, and that necrosis of tissue in a neck fasc case. Very wide range of illness. And so to get this wide range of disease, we have to have a fairly broad listing of virulence factors. And this could honestly be a lecture, a textbook chapter, probably a textbook in and of itself, is the group A strep virulence factors. And so we're just going to highlight a few quick ones here. So the M protein is the one that everyone is probably most likely familiar with, or the EMM gene. Small bit of nomenclature for molecular biology. Whenever you see something written as lowercase and italics for a name, that is referring to the gene name, so EMM, lowercase italics. If this was non-italic with a capital E, that is referring to the EMM protein. You'll see that a lot through literature, especially as you look at things like MEK-A, the gene, versus MEK-A, the protein in MRSA. So the M protein is the archetypal protein, or the pathognomonic, so to speak, protein for group A strep. This is what we call group A classification, is based on detection of that M protein. That group A, group B, group C all refers to the work of Rebecca Lansfield, an American microbiologist, I want to say in the 1950s, who did a lot of work classifying group A strep based on serum reactivity to surface antigens. And the defining feature of group A strep was detection in serum of that M protein. And so this becomes a critical protein for group A strep. This does a lot of things for the pathogen. For one, it's a huge adhesion and attachment protein. It's a significant protein to find a tissue target, attach to a tissue surface, and adhere to that tissue surface. There's other proteins involved in that as well, but the M protein plays a very large role. It's also the protein that gives a lot of the tissue tropism behind where group A strep wants to colonize. So certain M strains or M types will preferentially colonize the throat. Others will preferentially colonize skin, and that's due to that tissue tropism of the M protein. M protein also has a number of roles in immune evasion. So M protein recruits factors from the blood, so factor H being a big one, and holds factor H to the cell surface. And factor H works to break down any complement that gets deposited onto the cellular surface. So if we think through our immune response, complement is a way of innately flagging foreign particles or phagocytosis. We call this process of flagging opsonization, or opsonophagocytosis, or improved phagocytic clearance due to an opsonized target. And so M protein works to recruit host factor H, which sees complement and breaks it down. The idea here is that by stopping that complement deposition, we're no longer flagging, we're no longer opsonizing group A strep particles or group A strep bacteria for enhanced phagocytosis by the immune system. The other thing it does very well is it can help to break down IgA. So our immune system, that failure to clear this through phagocytosis is very easily overcome if we have good, strong priming of the immune system to that particular strain of the M protein. And this is typically seen through IgA as a secretory antigen, or correction, secretory antibody that's very important for mucosal immunity. So IgA against a very specific M protein helps for that clearance approach. Group A strep with the M protein, what it can actually do is indiscriminately bind the Fc region, or the main core of IgA, and break it down. So if we think that IgA or any of our immunoglobulins, you have the main core and you have our two tips. The tips are what binds to a pathogen. That main core is what is recognized by self. Group A strep can, in essence, bind the backside of IgA, of immunoglobulins, and fracture the antibody, thereby rendering it useless. Hyaluronic acid capsules, try saying that 10 times fast. Hyaluronic acid capsule is another significant immune evasion factor that group A strep brings to bear. And so, bacterial capsules, we can kind of think of, you can almost imagine grabbing a wet bar of soap and it slips out of your hand. And so there's an immediate benefit that capsules give into preventing phagocytosis, as they can often shed layers of the capsule as they're being enveloped by a phagocytic cell, and it scrapes off part of the capsule, but the bacterium escapes. You grab that wet bar of soap and it just slips out of your hand. But this has a number of other features as well. It also hides a lot of cell surface antigens from the immune response. We coat it in the capsule and it just can't be seen by antibodies, by circulating cells. But there's one other significant feature here is hyaluronic acid is very, very common in a lot of our connective tissues. And it's a very, very similar structure to what group A strep is creating. So much so that group A strep does actually create a hyaluronidase enzyme to break down host hyaluronic acid. And this is very important because this is something we call molecular mimicry, where because it's so similar to self, our body has a very, very hard time creating an antibody against it, because we've trained our immune system to say, do not create antibodies or cellular responses against our own cells. And so the immune system sees this capsule and says, I recognize that, that's ours, we're not going to touch it. What can happen, and this is a hypothesized mechanism for rheumatic fever and rheumatic heart disease, is that if you start to get antibodies against this capsule, once you clear the pathogen, those antibodies now starting to look for a different target. And they look at things and they say, hey, that connective tissue of the heart, that kind of looks juicy. Let's go attack that. And you lead into that acute rheumatic fever, rheumatic heart disease. And it's thought to potentially be that autoimmunity to connective tissues driven in from this molecular mimicry that group A strep brings. Secreted enzymes, we've kind of alluded to one down here with hyaluronidase, but there's a number of other enzymes that get secreted. The idea with these is that as you get movement through connective tissues, think necrotizing fasciitis, where group A strep is very rapidly advancing up the fascia of the body. It wants to break down those connective tissues to allow rapid movement through tissue. And so these secreted enzymes have a huge impact for that. There's DNases as well that are a way of escaping something called nets, neutrophil nets, where it secretes out DNA and histones to capture pathogens. And the DNases will actually break down that DNA and allow it to escape those neutrophil nets. Lastly, I threw on here those superantigens and exotoxins. We already alluded to the impact that superantigen has in driving severe streptococcal disease, or toxic shock syndrome rather, and scarlet fever. That idea of widespread activation of a Th1 or pro-inflammatory immune response across the body. And I've been asked before of, well, what's the benefit of that? Why would a pathogen want to just broadly activate a pro-inflammatory immune response? Because wouldn't that just help the immune response clear the pathogen? And the analog I kind of put to this is, imagine your hospital, or imagine you're a large commercial building. Someone pulls a fire alarm on the 9th floor, firefighters respond, they go to that alarm panel, they go, all right, there's the light blinking, it's on the 9th floor, up we go, 9th floor. Hey, there's the pull station, there's a fire, let's put out the fire. Great, fantastic, we can target our response. If that same fire crew shows up and they look at the panel and that entire panel is blinking, every single alarm on every single floor, they have no idea where to go. So they split resources. They call in more resources, but those resources get split as well. And so that's kind of what you can imagine the immune response is doing when you have this broad superantigen indiscriminate activation of the immune system on a systemic level. Now your immune system has so many areas that it's being pulled to respond. It can't mount an effective response in any one area. And it allows group A strep to kind of escape recognition and delay killing and attack from the immune system. Now, when I ask the question of what factors really make group A strep still such an effective pathogen, one thing that kept coming up and is not on the screen here is the idea of antibiotic resistance. Now, it's not to say group A strep does not have any antimicrobial resistance. There is certainly some resistance to sulfa drugs. There's certainly some resistance to many other pathogen or many other antibiotic groups, a lot that hit protein synthesis, so our macrolides. But what is missing is effective resistance against penicillin. And so in the literature, there's a term that's always thrown around. It sounds so nice. It's group A strep is exquisitely sensitive to penicillin. Even when other pathogens, penicillin, like bulk, plain, simple penicillin no longer works, but first-gen cephalosporins are fine, amoxicillin's fine, some of these other simple beta-lactams are fine. Group A strep is still widely susceptible to penicillin. And that's not to say other pathogens or other strep species are not penicillin resistant. Pneumococcus, Streptococcus pneumonia, we see penicillin resistance emerging quite frequently, but we've never seen penicillin resistance for group A strep. And scientists, of course, want to know why at some point. And in a lab, they tried to artificially bring in a modified penicillin binding protein to bring that same degree of penicillin resistance. So the idea with penicillins is they impact penicillin binding proteins. Penicillin binding proteins are responsible as the cell walls are being elongated, structurally modified, cleaved during mitosis. The restructuring and cross-linking of the peptidoglycan is the responsibility of penicillin binding proteins. And so when you have beta-lactam antibiotics, they will irreversibly bind those penicillin binding proteins, inactivate them, and the bacteria can no longer reshape and cross-link that cell wall, and it kills itself. And so they brought in this penicillin binding protein modification that made it resistant to penicillins in group A strep in a lab setting. And what they found was they could make it resistant, but now other virulence factors suffered. One of the big virulence factors that suffered is it could no longer effectively produce the M protein. And because of that, its ability to effectively colonize cell surfaces and its ability for immune evasion was significantly hampered, and it no longer had that same ability to survive within the host. So we can call this molecular fitness. By bringing in new genes, there is a tax, there's a cost to create new proteins, to create new enzymes, to create new genetic material. And that means that the pathogen or the bacterium now has to split its resources between making these new proteins, these new genes, modifying or replicating this new DNA, and keeping its regular genome functioning and operating. And so as it starts to create new things, other proteins start to suffer. And like I said, the M protein was one that really could not keep up. And so because of that, bringing in that resistance actually makes it easier for the pathogen to be cleared because of that impaired immune evasion. This really speaks to this fact that group A strep is a host-adapted pathogen. It has over thousands of years so exquisitely well tailored its virulence factors to survival, infection, colonization, and immune evasion within humans that it isn't quite at that point where its finely tuned balance of virulence factors can have much more added to it without throwing it out of balance, which is all of the better for us because, of course, that makes it that much easier for us to treat. The last kind of aspect as to why group A strep remains such an effective pathogen today I really want to touch on is this idea of antigenic diversity. And so I alluded to this when talking about Sir Almroth Wright, who did a lot of work trialing vaccination strategies for group A strep, trialing serum therapy strategies for group A strep, where you would passage the organism through a horse or another animal, collect off the serum, and provide that serum to a patient. And unfortunately, what he found is that this only worked for that very specific strain of strep. But in the early 1900s, it was very hard for him to figure out what strain of strep any particular patient had. And when we look at the diversity of group A strep, it is immense. There are hundreds, I think at last count, 220 individual M proteins. Within those M proteins, there is additional subtypes or subtypes of those M proteins. There's additional antigenic variations of the strains outside of the M proteins that leads to thousands of lineages of group A strep, thousands of antigenic profiles of group A strep. And this makes it very hard for us now to really nail down good, solid immunity to any one type. So that is the who, the what, and the why of group A strep. Why is it still such an effective pathogen today? And fortunately, why are we still able to treat it with penicillin? But what's driving this January 2024 experience? What's driving that massive surge of cases this year and last year, frankly, compared to what we typically would experience pre-pandemic? And so I will fairly warn that there is some broad speculation ahead because I don't think, at least at the time of this recording, there isn't a good, solid, catch-all scientific explanation behind this. There's a lot of scientific theorization, but we haven't found the solid proof, the smoking gun. And realistically, it is likely multifaceted. The first question I always get, and the question our resident and intensivist asked me was, is there just a hypervirulent strain going around? Is there a new strain that's broken out, just like COVID was a novel coronavirus? Something new has hit the patient or the human population. We've never seen it before, and it's just ripping through us. And I think that's a very, everyone wants to jump to that conclusion because of that post-COVID mentality. We still have that inherent memory of novel pathogen emergence with COVID. And fortunately, Public Health Ontario does routine surveillance of group A strep. So they'll do M typing, so typing of the M protein. And then various groups also do whole genome sequencing to look for broader variation outside of just the M protein. But again, going to that Public Health Ontario iGAS surveillance report, we see that there isn't necessarily one particular strain that's popping up. We see a lot of EMM1, but we typically see a lot of EMM1 floating around in Ontario. And then we get this kind of smattering of other M protein types across the province. And so what this kind of suggests to us is there isn't necessarily one that's emerging as novel, at least not right off the cusp. But what really helps to solidify that conclusion is when you look at the fact that it's not just Ontario with increased group A strep rates. We're seeing massive surges of group A strep in the rest of Canada, in North America, in Europe, in other parts of the world. And when you look at those profiles of M proteins, it differs in other parts of Canada, in other parts of the globe, in other parts of North America. And so this idea of we're seeing resurgence, we're seeing surges everywhere, but that breakdown of M proteins is different, really helps to point us away from the idea that this is just a novel hypervirulent strain that's broken into the population. Of course, whole genome sequencing is always being done on these. There might be a case that these 213 EMM1 types might have some other mutations in the rest of their genome that's really helping to drive invasion. And so time will really tell on that, but the at least cursory glance doesn't really support that idea. So the next idea is one of loss of mucosal immunity. And we alluded a little bit to what drives mucosal immunity when we're talking about virulence factors, is IgA is a significant memory effector for mucosal immunity. It's a secreted antigen, antibody. But because of that, it also is one of the lowest or one of the shortest half-lives of any of our immunoglobulins. It very, very readily breaks down, and you need fairly regular priming to maintain those levels. And so before we try to tie this to group A strep, let's look at something else that we've seen a lot of, which is influenza. Now, this is from the Canadian Flu Watch database. It's actually the 2022-2023 season's data. But I want to highlight a few things here. So this dotted black line with the gray error bars is our 5-year pre-pandemic average. And we saw something very unique through COVID. As we alluded to before, there's a dashed red line that you can barely even see along the bottom here that represents 2020, 2021 rates, where we saw virtually no influenza whatsoever. And we think, why did we see no influenza whatsoever? Well, universal masking in all public spaces, lockdowns, gathering restrictions, the inability for large crowds to come together and for that transmission to readily occur. And so we saw very, very little influenza in that year. With that, we saw very little of any other viruses in that year. 2020, I'm sure many folks who were in hospital remember, despite those first few waves of COVID, we kind of sat there sometimes going, our ICUs are full, but we're not seeing much else hitting the rest of our hospital. We're able to block beds, close units, certainly things that we can't do today in 2024. Into 21-22, we of course had that same pattern all through the fall and into the early winter and into March. We started lifting pandemic restrictions, and we had this sudden resurgence of influenza, and it kind of died back down, a very, very late season surge. That brings us into 22-23, where we saw with flu this very early into September, October, very rapid increase in cases. a near vertical climb in our detection rates with significant number of cases requiring hospitalization, significant number of general identified cases in a very, very short period of time. This was also repeated with RSV, repeated with other viral pathogens. This idea that these viruses we haven't seen for a number of years are exploding again out into the mainstream. So this perhaps doesn't look that dramatic when you consider it, okay, it came up really quick and then dropped off, but this is also percentage positivity. So when we look at 2019 data versus 2022 data, this is now total case counts by week, and you see that our numbers are over double in a lot of those weeks. So we had a large volume of activity compressed into a very, very, very short time frame. But perhaps what is more telling is the fact that we're also looking at our hospitalized patients per 100,000. The graphs look very, very similar, but when you look at the actual breakdown per age demographic, they are about double what they were in 2019. And so that's what we really saw with flu and with other pathogens, was this idea of, okay, we're seeing a lot of detection, but that detection somewhat the percent positivity is somewhat impaired by the fact that we're testing a lot more. But the volume of cases being admitted to hospital, the volume of sick in the community, the volume of deaths is significantly higher than pre-pandemic. This was also the year, I'm sure many young parents of young children or new parents will remember, was the time that you would go to a drugstore and you couldn't find any pediatric Advil or Tylenol anywhere. This was the period of time where across Ontario, pediatrics units were full. Pediatric ICU beds were full. Patients were being sent to Manitoba. Patients were being sent to Detroit. Patients were being sent anywhere they possibly could for pediatrics or pediatric ICU beds. For my own personal story, we had in the September of this year, when my son was 6 months old, we had swimming lessons and lovingly contracted COVID at swimming lessons, and a few months later contracted RSV. We're not entirely sure where we got RSV, but we did get RSV and did get lab confirmation of that. And trying to find drugs was just please, just give me one vial of pediatric Motrin, please. I just need something to knock his fever down so we can sleep. So the burden of disease, very, very high. And when we think through the hypothesis as to why, it gets back to the idea of mucosal immunity. So when we've seen nothing for a few years, those IgA responses start to wane. They start to break down. Some of our other responses start to wane, start to break down. There's memory cellular responses that generally rely on fairly frequent priming that start to just dissipate. And because of that, now when we're exposed to the next strain of influenza, we're lacking some of that cross-protective antibodies, cross-protective epitopes. And so we're a little bit more susceptible to rapid disease. We're a little bit more susceptible to more severe disease, a little bit more susceptible to contracting it when we're exposed. Now, this unfortunately was very poorly twisted in the media with terms like immunity debt, to say that we should never have done any of our COVID-19 pandemic measures. And that's not at all what I am trying to endorse here. Our COVID-19 pandemic measures were, frankly, the best approach we had at the time to blunt the sheer burden of COVID illness and make sure that we weren't dealing with severe cases of COVID, especially into Delta, especially into Omicron, on top of severe cases of influenza and RSV and other pathogens. But it is a reality that we're seeing this idea of altered transmission of other pathogens in the post-COVID era, and it's likely driven by shifts of disease transmission dynamics throughout COVID because of those pandemic restrictions. So let's go back to group A strep and talk why possible mechanisms as to why are we seeing this surge. So certainly that idea of hypervirulent strain, certainly on the table. Well, potentially not, if not the smoking gun, potentially not a major etiology there. But let's look at some of this idea of immunity. So for one, we have waning IgA at mucosal surfaces. IgA does help to prevent group A strep colonization, does help to prevent group A strep adherence, does help to prevent invasion if you have the appropriate IgA for that strain. And so if we start losing some of those strains, we're not getting exposed to strains of group A strep anymore, so we're not constantly priming those responses. Now group A strep hits, and it's a little easier for it to colonize mucosal surfaces. Now it's a little easier to colonize. It can start growing a little bit. Now that it grows a little bit, perhaps it's a little easier for it to invade. Next up, we can add on to that this idea of increased frequency and duration of viral illness. And this is a really, really cool concept here, is this idea, if we go back to this, we haven't seen flu, we haven't seen RSV, we haven't seen metapneumo. And so now we get exposed to it, we're a little bit more likely to get infected. When we get infected, we're a little bit more symptomatic. Symptoms last a little bit longer. And instead of I get exposed to flu, I've seen something similar to it, so my body prevents infection, or maybe I get an infection, I get a day or two of increased nasal secretions, increased mucus production, and then my body clears it, or rhinoentero or metapneumo or any of these other viruses. Now my probability of infection is a little high. With my probability of infection a little higher, okay, my symptoms last a wee bit longer, bit more severe. Instead of 2 days of runny nose, I'm at 5 days of runny nose, 6 days, 7 days of runny nose. And what that drives is it creates increased mucus secretions in our nasopharynx, at our throat, and that increased mucus secretions helps to give group A strep a little bit of a replicative niche. You can almost think of it as the ability to avoid the immune system by being in a biofilm. It's not quite a biofilm, but it's that idea that group A strep is kind of hiding in mucus and allowing it to grow and cultivate and escape immune evasion a little bit. And there's some virulence factors that really help to point to this direction of this survival within that mucus on mucosal surfaces. Last, of course, we have that idea of pull the fire alarm on every floor of the building, and firefighters don't know where to go. This general idea that you're getting more and more illness, more and more viral infections, and that does take a toll on our immune system. It does drive down the ability to rapidly respond. And so now we're more at risk of secondary infections. So we have increased rates of colonization and now slight immunosuppression from frequency of illness that potentially drives us into increased risk of invasive disease. So again, none of these are necessarily the smoking gun. Science has definitively said this is the mechanism, but there's a lot of evidence pointing towards this kind of multifaceted approach and multifaceted interplay of the immune system and other disease into really saying, why are we seeing this resurgence or this surge of invasive group A strep? All right, so enough about the immunology and the microbiology behind it. Let's just get into how do we manage it as IPAC? Because of course, group A strep is one of the pathogens that we should be concerned about, and it's one of the pathogens that a lot of our practices around empiric isolation pending confirmation is kind of has a focus often in group A strep and a few other bacterial pathogens. So we are primarily concerned for invasive group A strep and peds, because peds are disgusting. And so I have a kid, I'm allowed to say that. So when you have slobbery kids with poorly controlled secretions and inability to effectively prevent environmental contamination. We're concerned about their pharyngitis. But for most adult populations and older kids, invasive group A strep is what we are concerned for an IPAC perspective. And so group A streps typically, and iGAS is if it's identified from a normally sterile site, blood, CSF, joint, etc., or you have it from a non-sterile site, so you have a throat swab positive for group A strep, and evidence of severity. So Streptococcus toxic shock syndrome with multi-organ dysfunction. And this is the MOH iGAS protocol. If you go to that protocol, there is some actual criteria on what does multi-organ dysfunction mean. Soft tissue necrosis, meningitis, or death. Death, of course, being a very obvious sign of clinical severity. And so this is when we consider something iGAS. And for the majority of patients, this is when we sit there and say, we want these patients in precautions. And when we think of our precautions, we go droplet contact precautions, and we want to discontinue precautions after 24 hours of effective antimicrobial therapy. Now, there's two kind of things that we can take away from this and ask that question of, again, why? So we go back to, let's talk droplet contact precautions. And that makes a lot of sense if it's in our throat, if it's in our lungs, droplet precautions, cool. I get that, makes perfect sense. But necrotizing fasciitis, so my leg has a necrotizing fasciitis. The leg is not the same as the mouth, so why droplet contact? And part of this comes down to this idea of group A strep loves to colonize the throat. In fact, necrotizing fasciitis, unless there's an actual wound that started as the portal of entry, there's this interesting idea that necrotizing fasciitis can be seeded from either a bloodstream infection or just transient bacteremia. So you have a lovely group A strep pharyngitis, or even just overgrowth and colonization in the throat. It invades into the bloodstream. It invades into the bloodstream and either causes a true bloodstream infection or just floats through the bloodstream until it hits terminal arteries. Now, terminal arteries are where the very end of our arterial network before it finally flips around and starts coming back. So fingers, toes, ears, nose are the big terminal artery groups. And so you think lower extremity terminal arteries, you have group A strep going through the blood, being deposited into those terminal arteries and capillary beds deep into our feet. And they escape and cause now a little bit of an infection into that skin. And we seed through the blood a skin infection or a connective tissue infection, and you get that necrotizing fasciitis without a wound. So the idea is the throat still poses a significant portal of entry via colonization for all of these other potentially invasive diseases. Not to say that it is the sole way that it's getting in, but it's certainly impossible to rule it out. What we really care about as well is if you have a severe invasive group A strep disease, there's a good probability that you have a particular strain of strep that is highly virulent, an M protein that is more conducive to causing invasive streptococcal disease. And so the concern is that you being colonized is far more concerning than most people with just isolated pharyngitis being colonized. And so that's why we go droplet contact, even when it's not a respiratory pathogen or a respiratory infection. It's the idea of pharyngeal colonization. Now, here's one that we tripped some folks up with when we did the live session is when can you discontinue precautions? And so most resources, and you can find this in a number of resources, it is 24 hours after effective antimicrobial therapy, which is nice for group A strep because virtually any beta-lactam is effective against group A strep. When you start to hit some of the other pathogens, maybe less so, but certainly beta-lactams, which is our go-to, you will have good group A strep coverage. What trips people up for this is the lack of the language with clinical improvement. And so people start to say, well, yeah, there's a big bloodstream infection. They've had 24 hours of drugs, but they're still sick. They're still intubated. We need to keep them on precautions. And the language in a lot of guiding documents doesn't actually add with clinical improvement, and adds that for a lot of our viral etiologies. And the idea with our viral etiologies is we've had some time, it's been 5 days, been 10 days, but you're still not getting better. The concern is you're still seeing that degree of viral replication, degree of inability for the immune system to clear the virus, and so you're still infectious. The real benefit and target of what we're trying to do with 24 hours of antimicrobial therapy is to knock down colonization. Not eradicate colonization, because 24 hours is certainly not a decolonizing course of antibiotics, but the idea that we're just trying to knock down our pharyngeal colonization to the point where they are likely not transmissible. Of course, the big thing we've learned through COVID, point of care risk assessment still reigns supreme. Routine practices still reign supreme. Patient still has significant coughing, significant respiratory symptoms. Point of care risk assessment, if you're going then to do an ENT exam on that patient, mask and eye protection is probably still warranted at a minimum. But from a precautions standpoint or a patient isolation standpoint, 24 hours of antimicrobial therapy, and we can discontinue that droplet contact precautions because we've likely knocked down that oral pharyngeal colonization. And so that kind of answers the why. Why do we take these precautions, and why do we pick our timeframes for when do we pull them out of coverage, both for diagnosed, unknown, definite group A strep, and for things like we are negative for viral etiology. We think there's a pneumonia. Let's give 24 hours of coverage with antibiotics. Or we have a suspected meningitis. We don't have an etiology. Let's give 24 hours of coverage with antibiotics. It's that idea of knocking down that oral pharyngeal colonization of pathogens that like to invade and colonize the throat at the same time. So with that, number of references here. What I'll do is for the YouTube video, I'll post this all in the comments, so you can certainly go to any of these DOI links. But a fantastic resource for the history of Group A strep. Great read, great audiobook if you're into audiobooks, you have long commutes like me. Demon Under the Microscope by Thomas Hager. Thomas Hager has a few other fantastic books about scientific and medical history. This really details the idea of how Group A strep helped to modernize and shape medicine, and the whole story of the discovery of Prontosil by Gerhard Domach as that first to market broad used antimicrobial drug, and a lot of the positive and negative history that drug really had. With that, of course, we don't have time. We won't be able to do questions as this is a virtual session, but certainly feel free to reach out to me, kstinson@smgh.ca, if you have any questions. Otherwise, thank you very much. Hope you enjoyed this session, hoping that we were able to go into a little bit more detail, give a little bit more meat to the materials with the extra time, and hopefully you'll join us for our virtual live session on invasive streptococcal disease as a case series sometime this summer. Thank you very much and have a great day.